So thank you all for being here. This is a wonderful turnout for a Friday evening. I'm happy to be here. So I'm a neuropsychologist, which is a little bit different from a neurologist. That's okay. I'm a psychologist who really focuses on the relationships between medical conditions and thinking skills. And so that line of interest has really led me to think a lot more about changes in thinking related to cancer and its treatment. Figure out how I guess I probably could have used my time to figure out how we move this. There we go. All right, so I want to speak a bit about the types of cognitive problems that patients will often describe, and talk a bit about what the research says in terms of why people who have had cancer may experience a change in their thinking skills, who might be more at risk for that, and what is the trajectory of cognitive change over time? What do we think is in the future? And then how can we manage these changes and have the best quality of life? So the term that floats around is chemo brain, right? People will often say that they aren't able to learn new things as efficiently. It takes them longer to complete tasks. They can't multitask or juggle. They can't keep as many balls in the air as they used to without making a mistake, and they can't find that word that they want to use. It's right there on the tip of their tongue, and it won't come to them, and it drives people batty. It's one of the most problematic symptoms that people will tell me about. And so cognitive changes in the face of cancer are really common. These are just data from a range of different cancers, people with a range of different cancers, who were on average about 4.5 years post-treatment. And they were simply asked, compared to other people your age, do you think that you have more difficulties with your thinking than most folks? And across all different types of cancers, about 46% of former patients say, yeah, I feel like my thinking isn't as good as my same-aged peers. And colorectal cancers are right there at the average. So a little bit less than half of patients will say, I feel like I'm not quite as sharp as I maybe should be. And these cognitive changes are often problematic to patients. They say that it's difficult for them to hop back into their occupations, their jobs, in the same way that they once did, or into their social roles. I often hear patients tell me that as they're finishing up treatment and getting back into those kinds of activities and roles, that they may start looking like their old self. They look healthy, they seem like they're doing well, but they feel like they're not that same person anymore, either in terms of their thinking or just their way of looking at the world. And so these can have a contribution in terms of your quality of life. And without getting really into the weeds of the biology, I'll just note that there's good reason to think that cognitive changes arise both because of the cancer itself and because of the treatments, right? So there's kind of a cascade of changes that occur in the face of cancer, and we see that there are changes in thinking skills even before patients undergo surgery, radiation, chemotherapy. We see that patients may take a bit of a hit in terms of their thinking. And then chemotherapy itself has a number of mechanisms by which it can affect cognitive functioning. And so both the cancer and chemotherapy have been known to cause changes in the structure of the brain, so the sizes of various brain regions over the course of treatment, and also how those regions function, how they communicate with one another, and how they help you perform your everyday tasks in terms of thinking skills. So in terms of who's at risk for more cognitive difficulties, there are a number of different risk factors. One being age. We know that age and chemotherapy share a lot of the same sort of mechanisms. The way our body ages, the same kind of biological processes in some cases occur via chemotherapy. And so we think that there might just be a synergistic effect, an additive effect, and so that older individuals may have a more difficult time with their thinking skills when they're faced with cancer. And there's also this notion of cognitive reserve. And that's the idea that vulnerable brains are more prone to cognitive decline. And what I mean by vulnerable brains are, there's a number of ways of kind of thinking about that or conceptualizing it. And one of it is intellect or educational background, kind of your native smarts, your God-given smarts. We know that people who are brighter tend to be able to take more of a hit in terms of their thinking, more disease pathology, a greater burden of disease before they start to show cognitive changes. So people who are really bright or very well educated, in the face of a brain injury, in the face of Alzheimer's disease pathology, and we think even in the case of cancer-related changes, they can take more of a hit before they start to show those cognitive difficulties. And the converse is also true. People who don't have as much native ability tend to be a bit more vulnerable. Similarly, people who have other health conditions that could be risk factors for cognitive decline, they may have more of a decline in the face of cancer and its treatment, simply because they already have untreated hypertension or diabetes that's not well controlled, or a history of brain injury or something along those lines. And then we know a bit more about genetics, that there are some genetic profiles that may predispose cancer patients to having greater cognitive difficulties. And these are not cancer-related genes. These aren't genes that your doctors would be looking for in terms of assessing your risk of cancer. The ApoE4 alleles are genes that are linked to Alzheimer's disease. So patients who may have, and if you look across all types of cancer, we see that patients who have 2 of the E4 alleles tend to have greater cognitive declines with their cancer. COMT genotype, there's certain genotypes that are in SNPs, and I won't get into all of it, but that's just to say that we're learning more and more about kind of individual vulnerabilities. These aren't genetic tests that your doctors would prescribe, your insurance company wouldn't, certainly wouldn't cover it, but in group studies, they help tell us a bit more about why some people might be more at risk. And the good news is for colorectal cancers, we don't see any link with the Alzheimer's gene. So we know that that doesn't seem to be as big of a player in this population. And then we also think about the dose of chemotherapy. These are data from breast cancer patients because that is really where we know, where we've learned a lot about cancer-related cognitive difficulties. Most of the studies are in breast cancer patients, certainly. And so these are data from women who are 2 years post-treatment. And what they show is that individuals who had a high dose of chemotherapy had a greater risk of cognitive difficulties 2 years out compared to patients who had a standard dose. And then on the very far right, patients who didn't need any chemotherapy, they just had surgery. Now, these people who just needed surgery probably had a less aggressive disease or a different type of disease. And so these groups aren't the same in every respect because their diseases are probably a bit different. They needed different treatments. But it does suggest that there may be a dose response with respect to the amount of chemotherapy or the dose and how cognition holds up. And these scores were not affected by depression. So it isn't simply an issue of mood, fatigue. It isn't how long it's been since you've been diagnosed or treated. It really seems to be something related to the treatment itself. And in terms of treatments, we don't have a lot of great data on specific types of chemotherapies and how they're associated with cognitive change, comparing one group versus another. The anthracyclines is one where we do have some data. It shows that women who are on anthracyclines tend to do more poorly on cognitive tests. So when we bring them to the lab and test them, we see changes in brain scans and how those brain regions are functioning. But when you ask, in this case, women who are on that medication versus those who are prescribed a different type of chemotherapy, the groups are really the same in terms of their complaints. They don't notice a difference. They feel like they're about the same. So it's not entirely clear that there's that you would notice a difference depending on what type of chemotherapy you have. But certainly we know that there are some chemotherapies where there are mechanisms that are plausible. There's reasons to think that they may lead to cognitive difficulties, but we really don't have any clear cognitively focused data that's been published in the literature on some of these medications. Okay, so when we think about the time course of cognitive changes, I think it's first important to talk about what I actually mean by that. What are we talking about? And so as a neuropsychologist, there are a lot of different types of thinking skills that I probe when I'm evaluating a patient or when I'm doing research. Patients often come in and they say it's my memory, but there's a lot more to your thinking than memory. And so processing speed is one kind of cognitive domain that patients will often report changes in. That they feel like they're a bit slowed down, they're not making connections as quickly as they used to, it's taking them longer to think through things. Attention and focus, patients aren't able to sustain their attention quite as long. Executive functioning includes things like your working memory. So that's not your ability to remember your childhood first grade teacher's name. It's if I give you a phone number and you're going to walk to the other side of that hallway and go write it down, you're repeating it in your mind, you're holding it in your mind and kind of telling it back to yourself. You're keeping it there. You have no intention of remembering it forever. That's kind of your working memory. So you're keeping it there and you're working with it a bit with the notion that you'll discard it later. But also organizing and sequencing and things like that. Language skills are things like your word finding, construction, your ability to kind of mentally manipulate information, and then new learning and memory. And so I'm going to go through, I think it's 4 studies, and these are all the studies that have been done in colorectal cancer that I've been able to find. They're all by Jeanette Vardy, who is out of Sydney, Australia, and she does a wonderful job. But usually in research, what we want to be doing is having one lab and one center try to find out what's going on, and then across the world, somebody else tries to do that same thing, and we try to replicate it. So right now with colorectal cancer, we haven't gotten to that point of replicating the data. So this is a reasonably big sample, 245 people, followed over time, but it's not the definitive answer in terms of what's going on with thinking skills. But what we have here are 3 different ways, it's kind of overkill, but it's 3 different ways of measuring whether or not people are having cognitive difficulties, 3 methods that neuropsychologists like to use. And these are data pre-treatment. So these are folks who have been diagnosed, but they have not yet had any intervention. And so this is really speaking to the notion of what cancer and the distress of a new diagnosis might be doing with respect to thinking. And so in the green, we have patients who have localized colorectal cancer. The blue is the metastatic group. And then the purple is healthy controls who are the same age and have the same basic demographic characteristics like educational background and things like that. And so what we see is that 45 up to around 50% of patients before they even start treatment will have some cognitive difficulty compared to 15 to almost 20% of healthy folks who are walking around. So it gives you some sense that the way we're measuring this and defining it, we're still capturing about 2 out of every 10 people as having cognitive difficulties, 2 out of every 10 healthy people. So we're being pretty stringent here. And weaknesses were most common before treatment in thinking speed. So patients were slowed down. Their learning wasn't as efficient. They weren't learning as much, and they weren't remembering as much. And they were having difficulty with attention and focus. So that's how they were doing on those paper and pencil tests. But when you just asked them, only about 1 in 5 said they actually felt like they were having much cognitive difficulty. So there's some cognitive difficulties that are showing up on testing that aren't necessarily being bothersome to patients at that point in time, perhaps because they're distracted by other things, right? And as we often find, women often will have more cognitive complaints. They're more in tune with their thinking or more likely to report cognitive changes, but they also found that women had more actual cognitive difficulty on the testing than their male counterparts. So patients really don't perceive their thinking as worse at this stage than healthy people. Women tend to have had more difficulty, and the localized colorectal group and the metastatic groups really didn't differ in their thinking. And another thing that is worth noting is that the stage of disease doesn't seem to predict how people are doing in terms of their cognition. And then if you follow these same individuals over time, this is showing this over 2 years. So we have baseline 6 months, 12 months, and 2 years. And these are localized colorectal who required chemotherapy, that's that CTH plus, who did not. The metastatic group who were followed for a year, and the healthy controls who were followed for a year. And you see that there's pretty decent stability over time in terms of the rates of cognitive impairment. And it's in those same types of thinking skills, thinking quickly, staying focused, being able to learn and remember efficiently. So these groups, it doesn't really seem to matter whether you're having chemotherapy or not. And all of the cancer groups tended to perform more poorly than their healthy controls. And they also perceived their cognition as a bit worse, particularly if they were receiving chemotherapy. So even if you're not, the patients who were receiving chemotherapy didn't actually differ from their non-chemo friends, but they felt like their thinking was taking more of a hit. And they had a reduction in their quality of life and their mood if they felt like their cognition wasn't good. And then this is, I believe, the fourth and last and most recent study looking at cognition in colorectal cancers. And relevant to this talk, the only real finding that's worth noting is that cognitive functioning and fatigue don't appear to be associated with survival outcomes. But we don't have a lot more, at least that I've been able to dig up, in terms of good quality, rich cognitive data. So I think it's always important to keep the magnitude of cognitive change in mind. So if I told everybody, I've got a pill here and it's going to make you taller, your next question will be, well, how much taller? Because I don't want to grow 3 feet taller. I'll take an extra inch or two. The magnitude, you can find statistical differences. You need to know how big those are to know how much they might really impact your life. And so the promising news is that the magnitude of change, the size of cognitive difficulties that people often experience tend to be pretty small or moderate. So this is a normal curve. This is IQ scores as an example, but you could plug in any kind of cognitive thinking. And the general population, the average is of 100. Most people, 68% of people who walk around, 2/3, are between 85 and 115 for your IQ points. And just to give some anchoring, once you hit like 115 up here in this purple range, you're thinking, maybe I could be a doctor or a lawyer. And once you hit 70 down here, that used to be the numerical cutoff for intellectual disability, or what used to be termed mental retardation, right? And so what we see in terms of cancer and the magnitude of change is that they tend to be really kind of small to moderate. Maybe you started off, a little bit above average and you're dipping a bit more towards average. Or you are solidly average and you're squishing a little bit more towards the lower end of normal. But what we're not seeing, is folks who are dropping down to the extent that because of their thinking changes that they can't engage in many of their activities, that they can't care for themselves. That doesn't mean that they aren't having challenges and having difficulties in some respects, but we're not generally seeing that due to the cognitive changes. And so one thing that really sticks out in this literature as a whole is that there's this notion that there's a discrepancy between how patients score on tests and how they feel about their thinking skills. And just because there's a discrepancy doesn't mean that there is not something kind of real going on, just because our tests sometimes don't pick up on what patients are reporting. And I like to show this slide. These are for twins with breast cancer. One had breast cancer, twin A, who's here at the top, and twin B did not. And they're about 2 years out after twin A was diagnosed and treated. And they brought these women into the lab and they gave them some questionnaires about their mood. Neither one was anxious, neither was depressed. They gave them tests of different thinking skills, and they performed about the same. Even though twin A, who had the history of cancer, rated her thinking difficulties as much more severe and much more impaired than her unaffected sister. So she felt like she wasn't doing well in terms of her thinking, but when you actually sat her down and had her do the test, she was able to pull it out and do right as well as her sister, who had never had cancer. And then they put her in the scanner. And they had them both do this very challenging, what's called an NBAC task. It's a working memory task. And the basics of it is that you see a series of letters on the screen. And if you're doing a one-back task, that's pretty easy. You say, okay, I saw a T. The next one is a T, and you say, ding, ding, okay, one back was a match. And then the X comes on the screen, and you say, nope, no match, because X is not the same thing as T. No match, because B is not the same as X. No match. No match. And then once you get to that second S, you say, oh yes, one back was a match. So that's sort of how it goes if I'm explaining it clearly. And then it gets more challenging. It becomes a two-back task. So you're seeing these things on the screen, and you have to remember, oh, I'm seeing an X, and two back, I saw an X. So it's not fun. Nobody likes doing this test. We torture people with it. So we put them, I didn't put them, they were put in the scanner, and they had to do this test of a challenging task. And again, they performed about the same at the end of the day. But what's really interesting is you see when they do even the most simple version of it, the one back, the sister who has the history of cancer, her brain is really working harder to get that normal score. And as the task gets harder, the unaffected sister, she has to work harder too. But you see all the way along that the patient with the history of cancer is having to use more cognitive resources in order to produce those normal scores. And if you think about going through life, having to have a revved up engine like that all the time in order to function, you can see how things fall through the cracks, how you're not as efficient, how you may forget things that, I don't think I would have normally forgotten that before all of this came into my life. And so I think this is a nice kind of explanation about what can be going on in some patients. And one thing we know is that our perceived cognitive difficulties, the extent to which we feel like our thinking has declined, is very strongly linked to mood and fatigue. And so that doesn't mean that we're not seeing these real biological changes. It just means that there are other things that we can target to help ramp back up our thinking skills. And so the terminology that's often used, among patients is chemo brain or chemo fog, that this is due to the chemotherapy. And we've spoken a bit about the fact that it's not just chemotherapy. We think the cancer has something to do with it as well. And so as researchers, we talk about cancer-associated cognitive change or cancer-associated cognitive impairment to try to broaden the scope of what we think might be contributors. And we know that there are a lot of things that could be going on that could be contributing to cognitive difficulties. Sleep problems, pain, medications, other life stressors, changes in hormones and depression, and a number of different things. And so my general approach is that what we need to work on are the things that we have some control over, things that we can intervene with, because there are medical issues that we're not going to be able to change. The type of disease you have, the treatment that's most appropriate for you, those are things we can't do anything about, but a lot of these we can, and so that's where we really can feel empowered to make a change in our thinking. And so the general principles that I go by are to use our areas of cognitive strength to compensate for weaknesses, to know that if I'm not very good at these few things, that I need to build up my strategies and find ways to work around it. It can take a while. You have to make things a habit. It takes a while to start doing things differently, but habits are one of the key ways to help keep us from having cognitive lapses. These are much more deeply ingrained than episodic memories. And by that I mean, if I asked you what's my name, most of you will not remember. It's a one fact, a little piece of information. But if you're going home and putting your keys and your wallet and your cell phone in the same spot every single day, you can wake up 3 months from now, and if somebody asks you where are your keys, you'll say, well, they're where I always keep them. It's ingrained, you know it, you're not likely to forget if you're doing things in a more habitual way. The other thing is to not multitask. There really is no such thing as multitasking from a brain functioning perspective. We don't do more than one thing at a time. We're always, no matter how fast we're doing it, we're toggling back and forth when we're reading on our phone and watching a television program. We're never really doing two things. And so what we're doing when we're trying to do two things at once is we're just reducing our efficiency at both things, at both activities. So that's why we don't text and drive, because we're not good at it. So active listening is really key. Patients will often say, my memory is poor. And in order to have poor memory, you had to have gotten the information in. You had to have been paying attention and hearing it, thinking about it, in order for it to be stored and then later pulled back out. So I can't remember anything that was said in this room before I walked in because I wasn't here to encode it. I couldn't get it in. And quite often patients will have attention problems. They're not there in the moment really listening and absorbing, and then they realize, well, I can't remember what we talked about or the details of that conversation or article, and it's because it didn't get in there. And so part of the way, the approach to really getting new information in is to make it personal, to reconceptualize information in your own words. So if you're taking notes, to use your own words, to paraphrase, to think about the context and make it a really rich experience whenever you can. So thinking about the room or the day or the people that you met, trying to think about things in multiple senses, just to make it as rich as possible. Reading is something that patients will often tell me that they're having difficulty with. They get down the page and they realize, nothing registered. I know my eyes went over it, but nothing got inside. And so there are these kind of more formal study guide ways of trying to prepare yourself to read new information, previewing it, asking yourself questions about what you want to learn, reading, reflecting, and it's a bit of a sort of a process. Something that a lot of patients actually find helpful is just taking notes as they go, whether it's highlighting or actually jotting things down, because it forces you to really engage and pay attention as you do things. And so in terms of memory, we've spoken a bit about this, that learning and memory, you have to get things in order to pull it back out. And so you have to be attentive, you have to attend to what's going on, and it helps when you try to link new information to other ideas and concepts. So you can think about the talk that you're at today and the talks that you've been at here before with other speakers or other information that you've learned about thinking changes and cancer. And we see this little brain here with these nodes, and nodes are connected, right? They're connected to different ideas. And so like if I say the word dog, for a lot of folks, the next thing that pops in your mind is cat, because they've been paired so many times together, right? Or the name of your dog, Sparky, right? And so by pairing information together multiple times, you make it easier to remember it and pull it back out. And so reminding yourself, linking it to information that will cue you is one way to help information kind of stick and come back out more quickly when you need to remember it. There's no getting away from kind of repetition. Repetition really works. The act of pulling something back out from memory strengthens it. And so you pull that idea back out from your memory, you jog your memory and you say, okay, I know there are 3 things I need to get from the store tonight after I get done with my day. And you pull it up and you think about what are those 3 things. And then over lunch, it's like, okay, I'm going to the store. What are those? Pull it back up, pull it back up, pull it back up, and you'll find you don't need your notes, your list when you get there. Simply that act of re-accessing it strengthens the associations. And it's also great to review information before you fall asleep at night. That is a time during deep sleep that our memories are consolidated. They're made more permanent. And so that's a big study tip for kids who are in college or in school, is to review information right before you go to sleep, because it'll settle in. So as long as you're not somebody who's going to become anxious by thinking about things that need to be done or worrying about tasks or activities, if you can kind of non-judgmentally work yourself through things that you think are important as part of your day and what you'd like to remember tomorrow, that can be helpful in getting them to stick. That said, I often will have patients say, I didn't need notes before, I don't want to use them now. And I think they should give it up. Use notes. There's so much technology, there's so many really wonderful compensatory strategies out there. The key is not to have this be Post-it notes all over your house. It really needs to be a system and a habit that you use and you rely on, and it is kind of logical and works for you. And so that can be as simple as an index card in your front pocket with your to-do list, or some of these apps that are available. And some of these are wonderful. Things like Evernote can sync across all of your devices. You can make voice messages. You can take a picture of yourself in your car at your parking spot in the big parking garage so that you can look at it and remember it. You can text from it and all of these sorts of things. So there's a lot out there to kind of help augment thinking changes when you feel like you need a little assistance. And then, we're all doing a lot, and making sure that you're setting yourself up for success can really be important. Try not to multitask. Give yourself a list of activities or break a big task down into pieces and knock one out at a time. Try not to be doing pieces of each, doing one thing at a time, completing it and moving on. Doing it in a quiet area, turning off your cell phone alerts, the email alerts, Facebook, Instagram is what kids are using now, but all of your alerts and kind of things like that that are going to distract you, and really devote yourself to the task at hand. And know that you may need to take a few extra minutes. You may need to give yourself extra time because you're doing things more slowly. You may need to check your work because you just don't quite trust yourself yet, and that's okay. If the goal is to get things done and to get them done well with few errors, then it's fine if that's what it takes. Self-talk is something that people often will talk about, and that's really just planning and walking yourself through your day, your activity, thinking about what I need, how am I doing it, and kind of monitoring yourself as it goes. Is there anything I've forgotten? It's pretty basic things that we do every day, but when we stop to kind of think about the ways that we talk to ourselves, it's another way to kind of engage in that self-talk, to engage in self-talk that is related to your thinking and that is non-judgmental, and reminds yourself to engage in the task that you're intending to engage in. So patients of all types always are asking kind of, what is it I can do to keep my brain healthy? Whether they're already cognitively healthy and they're worried about aging, or they have some sort of a disease or condition. And so, the good news is that there's no one activity that's going to save your brain. If you don't like crossword puzzles, if you're not, waste your time doing crossword puzzles. That's not necessarily going to work for you. What the literature really shows is that healthy brain aging occurs when people are doing diverse tasks that are novel to them and are challenging and often social. There was just an article in one of the big papers, noting a big research study that just came out about, what is the best physical exercise you can do to help preserve your thinking skills into older age, and it's tennis, which makes a lot of sense because it's vigorous and it's hard to play tennis, but you're also social. You have to have somebody there with you. You're engaging with them. You're trying to figure out what they're going to do next. So you're using a lot of your mind in addition to using your physical body to keep yourself and your brain healthy. But just like physical exercise, our minds adjust. So you need something that's novel and challenging. If you're doing Sudoku and you're crushing it at every single level, then that's not a task that's really going to keep you sharp. You need to move on to something new. So socializing, picking up a new hobby, trying to get out in nature, doing things that introduce you to new concepts and ideas can be really helpful. So in terms of what the data show, where is there research to suggest what's helpful in keeping our thinking strong in the face of cancer? So using those compensatory strategies that we talked about before, cognitive rehab can be helpful. That's, rehab interventions are typically designed for folks who've had traumatic brain injuries or strokes. They tend to be focused on folks who are having a lot more difficulty than the average cancer patient that I tend to see at least. But they can still help you really integrate some of those compensatory strategies into your everyday life. We have rehab folks here who are great at helping you figure out how to use those new apps and integrate it with all of your devices and get it up and running and try, troubleshooting with you. Physical exercise is great for your thinking. We talked about that tennis study, but it can be really low impact. Studies show that Tai Chi, gentle yoga, those all have effects on our thinking skills. It may take about a month for them to come on board, but for your thinking to improve, but that's reasonable. And they also really help with things like mood, fatigue. We know that exercise is great for fatigue, and it helps with our other medical conditions like high blood pressure, diabetes, all of those things. And then addressing things like mood problems, sleep, substance abuse, and pain. All of those are things that can depress our thinking skills. And so once you address those, your thinking often will improve back to normal. We don't really have any good evidence, or the data say thumbs down, to things like puzzles and word searches. Computerized brain training, some people love the Posit Science and Lumosity, and I've played them and they are really fun and interesting. But the data suggests that you'll get really good at those games, and it doesn't necessarily generalize to other areas of your life. So you might not still be able to find your car in the parking lot just because you've gotten a lot better at these games. If you like them and enjoy them, by all means, don't sue me, Lumosity. Definitely they can be really fun, but the data really isn't there yet to suggest that they're going to be helpful. Dementia drugs like Aricept and Namenda don't tend to be helpful in patients who don't have dementia. And ginkgo biloba has a lot of promise in animals. Give it to your rats and mice, but it's not going to help humans, unfortunately. And I spoke a bit about this. Depression, anxiety, and fatigue. These are really big issues that we see frequently in patients who have a history of cancer. They undermine your thinking skills. Even if you've never had cancer or chemotherapy, if you have depression, if your sleep isn't good, if you're really anxious, I wouldn't expect you to be thinking as clearly as you could be. And so, these tend to be under-recognized and under-treated in cancer populations. And so it means that patients who are experiencing this may have to really be a bit proactive and say, no, this is something that's bothering me. I want to address it. I want to make a move on that, because it's something that your providers may not bring up, or they may imply that it's a part of the process of going through something stressful, and that's not necessarily the case. We know that there are things we can do to help you feel better. Risk factors for having anxiety and depression in the face of cancer, it's really having a pre-existing history of either of those, and having a worse time physically, having a lot more psychosocial stressors. It makes sense. The more you're going through, the more challenging it is for folks. And we know that patients with cancers have a higher rate of depression and anxiety and adjustment disorders compared to the general population. And we know that while a lot of patients will have some real anxiety or distress right off the bat, you've just been diagnosed, you're going through a whole lot, and over the course of time they get better, treatment comes on board, they get a sense of control and know what the future holds. A lot of patients will find that their mood symptoms subside, but there seem to be a smaller number of folks where it really just, their anxiety or depression starts high and it stays that way over time. And so these are data for women with breast cancer, but we see over 20% who make it out to, I think that's 2 years, and have anxiety difficulties. Same with depression. Folks who make it out a year, there's still a fairly high proportion who are still meeting criteria for clinically bothersome depressive symptoms. And so we see that about 1 in 5 will still have symptoms. And so these are issues that can be addressed to help improve your quality of life, but also to improve your thinking. And to treat mood and anxiety, certainly exercise, proper nutrition, things like this, getting psychoeducation about your condition, about getting support. Psychotherapy and supportive counseling can be really helpful. I'm a psychologist by trade, so I'm really biased towards therapy. Our options being therapy and medication. What I really love about psychotherapy is that properly done psychotherapy can help you build tools and develop skills that will really stick with you for the rest of your life. Whereas medications can help you ride out a hard time, and they're perfectly acceptable. And if those work for you and are the best, you think that's where you want to go, I'm all for it. But I do think that there's something nice about psychotherapy in terms of the way that it gives you a new skill for life. So we know that there are a number of different types of interventions that can be helpful and are efficacious when you're having mood or anxiety problems that are contributing to thinking difficulties. And I talk a bit about, I'll mention cognitive behavioral therapy. That's really a very structured therapy that's focused on learning about your thinking skills and the way that you think and tend to perceive information and process it, and how we can kind of shift that into a more healthy way of thinking and evaluating your thoughts. So it's not talking about childhood. It's not the laying on the couch kind of notion of psychotherapy from years back. It's a very directed, targeted, you're going to have some homework, you're going to fill out these, you're going to be rating symptoms kind of an approach that tends to be fairly time limited. So I know that the notion of therapy can turn some folks off. And then fatigue is a really big one. Nobody is thinking as clearly as they can be when they are fatigued. And it's very distressing, right? And so cancer-related fatigue is a specific type of fatigue that is persistent. Patients say they're either physical, emotional, or cognitive tiredness. It's not proportional to how much activity somebody's engaging in, so it's not like if you just stop and rest for a weekend, you'll bounce back out of this. It's really kind of a persistent thing that's just sticking with folks. We know that it does tend to improve about within the first year or so after treatment completion, but about a third of individuals will still have persistent fatigue issues 1 to 5 years post-treatment. And some studies have found that about 20% of cancer survivors will have persistent fatigue even a decade later. There are a lot of different risk factors for that. Some of them are medical issues like anemia and thyroid problems, medications, poor sleep, having more psychological distress. And there are a number of interventions. So we see that psychostimulants, those are things like Ritalin and Concerta and those ADHD type of medicines, they're helpful if people are having really severe fatigue, but not so much if your fatigue is kind of mild to moderate. They don't tend to help you. If you have major depression and you're tired, then a stimulant can help improve your fatigue. But if you're not depressed, a stimulant's not going to help you much, or an antidepressant's not going to help you much. And then we don't have any good data for any kind of a supplement, no vitamins or anything that really consistently improve fatigue. But there are a lot of non-pharmacological interventions, things we can do. Lots of different types of psychotherapy, but also exercise and yoga. Those things have been empirically shown to really help with fatigue in cancer patients. So they can be really fabulous. And we just don't have much data on acupuncture or mindfulness and those types of things. So there are more studies going on right now, but there's no real take-home message. And I like to bring up this study. This is a new one. It was published in JAMA Oncology this year, looking at treatments for cancer-related fatigue. And so this is a meta-analysis, meaning they smushed together the data from a lot of different studies. And so they were looking at exercise and psychological interventions, either alone or together, during treatment, after treatment. And what they found is that during and after treatment, exercise and psychological interventions are effective at reducing fatigue. It doesn't matter what kind of exercise you're doing. So you can be lifting weights, you can be doing Tai Chi. Any kind of exercise really seems to be helpful. Cognitive behavioral therapy is particularly helpful in terms of the types of therapy. But both interventions work significantly better than medication. So in terms of fatigue, your best bet really is to be moving and to perhaps engage in some type of therapy. I like to talk a bit about healthy sleep habits because this is something that can really contribute to fatigue in some patients. Our sleep behavioral specialists, we have a whole clinic over at Bayview run by Michael Smith, and they're great. And what they tell us is you should be keeping a regular schedule, meals, medications, exercise, getting up at the same time every day, even on weekends, trying to avoid naps, or conversely making them a regular feature, something you give yourself a chance to rest every day. Avoiding caffeine later in the day, avoiding alcohol before bed. It can help you, alcohol helps you fall asleep, but you're much more likely to pop up awake at 2 or 3 in the morning and be unable to fall back to sleep. It kind of wakes you back up in the middle of the night. And try not to be, don't smoke or use nicotine because those are stimulants. Don't be too hungry, don't be too full, which can be just right. Exercise for some folks tends to really rev them up, and so doing that in the evening can maybe be a bad idea if you're having problems with your sleep. Giving yourself rituals. The sleep doctors will say that your bedroom should be a cave. It should be cool, it should be dark, it should be quiet. And then, they tell you don't go to bed unless you're sleepy. If you're having a lot of problems with insomnia or falling asleep when you get into your bed, don't go to bed until you're tired. If you go to bed and you're not asleep in 20 minutes, get yourself up, go to a different area of the house to engage in something calming like reading, and then, give it another shot when you're feeling sleepy again. And your bedroom should not be an office and an entertainment center and everything else under the sun. It should be for 1 to 2 activities. That's what they tell us. So, cognitive difficulties, fatigue, and mood changes really are common following a cancer diagnosis and treatment. Certainly not everyone will feel like they're affected, but many patients do feel like this is something that they're dealing with. They can have a large effect on your quality of life, how you feel like you're doing. And there are clear biological as well as kind of psychosocial causes for these changes. It's really most helpful, I think, to address the things that are within our control, that kind of the low-hanging fruit. What are the things we can actually, we're empowered to change? And those are our mental habits, those are our health behaviors, and those are really shown to be able to improve our thinking skills, our mood, our sleep, our anxiety over time. And so, these really range from I've got to flip this, basic self-care, nutrition, exercise, sleep, to more intensive interventions like cognitive rehab and medications and therapy. But there really are a range of things that we can be doing to try to address these issues if it's something that's bothering you. So what else can you do? Well, I'm a neuropsychologist, so I'll make a plug for neuropsychology. What we do with patients when they come into the clinic are to really assess your personal strengths and weaknesses, to find out about what are the other contributing factors, those other areas of low-hanging fruit that might be affecting your thinking. And so do we need to get you to a substance abuse counselor? Do we need to get you to a sleep clinic? Do we think an antidepressant or an exercise regimen is appropriate? And what are the things that you're dealing with? Are you getting back into the workplace and you feel like you're not quite ready? Are there some workplace accommodations that maybe we should try to put in place so you can ease back more efficiently and get a bit of success under your belt before you're going full steam ahead with your activities? And then I actually really like this book. This was written by Shelley Kessler. She's also a neuropsychologist. It's, no more than 100 pages. It's pretty cheap on Amazon. But it talks through some of the things that we've spoken about today, and it's a nice little reference for folks. And so I will end there, and I'm very happy to take any questions that anybody might have.
In the last week, there's been an article on a new kind of medication that seems to be very effective. Are you familiar with the placebo
Yeah.
studies?
Yes.
Does that fit into any of the things we're talking about?
Right. Well, when we think about placebo trials, so what she's speaking about is the fact that when you give a placebo, a sugar pill, to patients who think that they're getting a real medication, it's a pretty solid 1/3 of people will respond positively to it. The power of our body to harness our own healing powers it's remarkable. It's one of the most robust findings across medicine. It's great. And so that's really important for treatment studies. So if I were to be telling you about a new drug or it's hard to do a placebo for exercise because people can tell. But certainly for medications that are geared towards improving mood, improving thinking skills, you need to have good placebos in place so that you can make sure that you expect both the placebo group and the real medicine group to improve. You want to make sure that real medicine group is improving more than the placebo, or else the medicine's just a placebo.
Just thinking about, in the CI, you're constructing, this whole map in your brain of what the world is, and your world, and it's a healthy world, and it's a future-oriented world, and then bang, you get this diagnosis of cancer, and that world is gone, right? The world you thought you knew, like I always say, it's like through the rabbit hole or a stranger in a strange land. For us it was, you have to reorient everything in your life in a foreign environment. So all of your learning and all of your assumptions are kind of out the window for a while. And part of me wonders if you just don't care about all the other stuff anymore. Like the things that you care about after a while, maybe the things that your brain is, more attentive to, and all the things that you used to think you had to stay up, and abreast of everything and be in charge. Maybe it just doesn't matter.
Yeah, that's a very good point. I think patients can be distracted by their concerns about their health. And you're right, the notion that your world is thrown off kilter and you thought the next week was going to be like this, and clearly...
You're learning where do you catch that, because if your old structures are all invalid now, you don't know what to do with that old model. Where do you put that information?
Absolutely.
It doesn't really fit anywhere, so you have to kind of start focusing on your world again.
I think you're absolutely right, and refocusing on the things that are important. I remember speaking to a woman who said, it's like you're juggling a bunch of different balls. Your family, your work, finances, faith, being a good friend, being, all these other things. And she said, you have to realize that some of those balls are made of rubber and some are glass. And you can let some of those balls made of rubber drop and just focus on the glass, your family, your health, the really core things that are important to you. And when you're ready, the other ones will bounce back into your life and you can start juggling them again too. But for a while, it's perfectly normal and healthy to zone in on the things that are really important and let the rest fall by the wayside if you're able to. That's okay. Go ahead.
So one of the issues I know that I have, and I know other people have, I don't know in this room, I'm active in quite a few different colorectal cancer survivor groups, is, and I know this is for me with the chemo brain, the feeling that you're either always, because we become more forgetful or have the lack of word recall, that your brain doesn't turn off. I'm always thinking about, what did I forget, what did I miss, what do I have to write down, where did it go, how do I do it, and, I'll wake up at 2 or 3 in the morning and I'm wide awake because I knew I forgot to put something in or didn't, it's the constant worry that I'm going to leave the oven on, or constant worry that I'm going to, not do something.
Yeah.
Is there anything, I guess, available that can help slow the brain down? When I say available, I mean, different exercises we can do. And,
Yeah.
I'm used to now taking, my schedule book, even though I'm going to go to bed. But because I run a business and I'm always so afraid I'm going to forget something or something, I'll write it down at night. I'll write it down. I'll keep a notepad, or I'll keep, because otherwise.
But it sounds like you're saying, it feels like you don't have that time just to rest and relax and not have to be worried.
It's
Yeah.
always on.
Yeah. It can be a lot. I mean, I think that making sure you're carving out time for yourself, for your self-care activities, making sure you're exercising and getting good sleep and nutrition. Cognitive behavioral therapy can sometimes help with, figuring out, what are the things that I need to worry about in some areas where my anxiety, my worry is revving more than it realistically needs to be, and so it can help give you some perspective and some tools for addressing those issues as well. But I hear you, it's hard when you've got responsibilities and when you don't trust your own thinking skills.
Guys, comment. Almost every slide that went up there, Mike, hit all of those. And so
Yeah.
appreciate what you're doing.
Thanks.
And I found it helpful. I had mentors ahead of me that kind of told me things that were coming both from a physical, surgical standpoint. They also shared some of the mental things that were coming. And so while it was jarring, it wasn't like I hadn't heard it. And so that was super helpful. The group was helpful. On Joy's point, I experienced mania big time during my chemo.
Did you?
As a 5FU guy, or I'm still whatever. I don't know if it was steroids or if it was chemo or it was a combination, but either way, there was no good sleep habits. It was just I couldn't, in particular, couldn't sleep, but I couldn't function at any cognitive level. So it wasn't like I was going to learn a new skill. It was crazy.
It's really, really hard. And the medications are often contributors. Steroids are a big one. There are certain cancers themselves that predispose folks to depression or anxiety. And a lot of these medications, your body's going through a lot and adjusting. And it's great to hear that you had some mentors, some people to kind of give you an insight into what's going on. Because as you were saying, this is a whole new world for a lot of folks. It's not something that you're necessarily well versed in and have good expectations. And so having the support of people who have been through it can be really helpful, which I probably don't need to tell you folks because you're here.
One of the things that I noticed for myself is that the job that I do, I seem to have focused on skills or thoughts that I never really honed in on before. Mm-hmm. So I seem to be finding myself doing some things a lot better than I ever did, and I don't know why. Then other things that I was really sharp on, I don't know, kind of touching on what the lady was saying over here, was it's just I don't care about it.
Right.
So I'm like focusing on stuff that a year ago I would have never thought of, but all the stuff that I thought I really loved and enjoyed, I'm realizing now, I didn't like it. So that's what I struggle with, is like, I knew who I was before. So then how do you, it's kind of hard to transition, and I know it's kind of been a year going to the third for me, so it's sort of like all new. But it's really strange that I'm happy with these things that I'm doing. They're a lot different than I've ever done. But on the same token, it's like
a change you weren't expecting from
yes, it's a different whole way of thinking and philosophy and everything. It's very strange.
Yeah, but it sounds like for you, it feels like a growth in a sense.
Yeah, it's like but it's a growth, but at 50 years old, it's like,
You thought,
I thought I was
you were
here.
fine the way you were, right?
You know,
Yeah.
now, you know.
Yep.
So that's what I struggle with. It's just that right there.
And that notion of feeling changed in some way, that there is a new normal, and that's something that gets spoken, talked about quite a bit. But I think that's something that's kind of fairly universal for at least patients that I talk to, that there's always a struggle about their identity and the way that life was supposed to be going for them, and now they have maybe a new way of viewing themselves, and new interests and new priorities, and that takes time for you to adjust to. It takes time for loved ones to adjust to as well, that this isn't simply a medical event that's going to take up X part of your life. It can be a bit more fundamental. Thank you all.